Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. How does a diagnosis shape identity, and what can clinicians do to prevent patients from becoming their condition? In this powerful episode, Claudia Cometa and Dr. Winsor explore illness identity, the emotional weight of medical labels, and the communication gap between doctors and patients. They discuss how eliminating gray space and using strengths-based language can reduce shame, restore agency, and make patient-centered care real, not just a buzzword. We thoroughly enjoyed this conversation, and we're sure you will too. Let's get into it.
So I want to shift gears a little bit and talk about something that you mentioned in your book called illness identity. Tell us a little bit about what illness identity is and maybe what clinicians can do to interrupt that pattern.
Well, first of all, just the way that we communicate a diagnosis, like you have cancer, it's like now we possess this thing, like we possess something and we don't want it, but we're like forced to possess this thing versus like, okay, I've been given a diagnosis of cancer. Society has taught us, and the medical system has contributed to that, has taught us what that means. So we already have the whole play of what that means. I have cancer means now I'm going to go get chemo. I'm going to lose all my hair. I'm going to probably have to quit my job. I'm going to have to do a GoFundMe because now I'm going to go into bankruptcy with medical debt. Like, you already know how that movie plays out. Like, yesterday that was not your identity, and now that's all you see. And so, I talk about in the book, like, then you make decisions based on that identity, right? Like, oh, well, maybe if somebody asks you to go, a friend asks you to go do something, now you're like, well, I don't know. Like, I have cancer. I don't think cancer patients don't do that thing. So, like, because I already know how this plays out. I've seen it in movies. I've seen it, I see the patients in the lobby I know that I'm only going to get worse. So no, now I have a new identity. I don't do those things anymore. And so it just plays out in so many parts of our lives. I'm also a certified radical remission coach. And in radical remission, the researcher looked into what are people doing who have been diagnosed, and this is not just cancer, but that's what I'm focusing on. But, what do people who are diagnosed with cancer stage 4 and sent home to die, but survive and thrive for many years, how is it different for them versus those who don't survive? Like, what are they doing differently? And so she identified 10 healing factors. And, one of those healing factors is strong reasons for living. And so, what can we as clinicians do to continue to keep that top of mind? Like, can we make that a priority of conversation at every visit? Like, keep their reasons for living top of mind at every visit. How do we incorporate some of those radical remission healing factors into not allow, or at least minimize, the likelihood that we completely spiral into this illness identity that we almost just transform into somebody we don't even recognize? Let's say we had never been diagnosed, and maybe we did have cancer, but we were never diagnosed. Would we live our lives completely different because we never took on that identity? So I think it's important, and may even be a good topic of discussion within a clinic, of how do we acknowledge the likelihood that this process is going to happen, and what can we do, what's in our power to help with this?
Yeah, so I'm reading a book called Anti-Fragile. It's a dense read. But one of the things that he talks about in there is exactly what you said about, I never knew that I had cancer. Maybe I did. I didn't get the diagnosis, but he talks about the difference between the knower and the doer. And he gives the example of, for the longest time, there was no word for blue. But if you, so you didn't know that this string was called blue, but if you saw two blue ones, you could match them together. And you didn't have to know that they were necessarily called blue, but you could see that they looked the same. So the difference between the knowing and the doing can lead to this concept of anti-fragility, or making us less fragile, less breakable.
I think that's paramount, is realizing that, we have a structure around words and how we use words and the impact of those words, those diagnoses. Even, I've even had people tell me, well, how do I'm so desperate to get this diagnosis off of my list of active because just seeing it is traumatic, They're not a different person because of a list, but they become a different person when they see it and they embody what that means. Then I have to be like people, like what I think people are, what I've seen people are who have that diagnosis. And that plays into biases too, if a physician sees fibromyalgia on the list of diagnoses. I mean, it's just the amount of biases that come just from that, right? Because it's a diagnosis of exclusion and what they know of other people who've been diagnosed with fibromyalgia. And so it can be, that in and of itself is its own illness identity, but how it's being translated on the physician side. So that's maybe another book that everybody needs to read. We'll add that to the Unreasonable Hospitality.
Yes. So in your book, you write, and I have it here in front of me, the medical system trains physicians to communicate in the fewest words possible. Patients, on the other hand, are seeking a deeper relationship that allows them to feel seen and heard. And you talk about something called gray space. So we've touched on communication a bit, kind of throughout our conversation, but how is this showing up in everyday encounters? What are the consequences and what can we do?
So yeah, part of this is understanding that contextual nature of medical training. And, I don't expect people to somehow now know all the nuances of all of the medical school training and now the residency, but just knowing that physicians are trained in a specific way of how to communicate. And they even talk about how they use the term high yield, meaning basically tell me only the things I need to know, right? Because I don't have all day. We have a billion patients, so we speak in a very high yield way, which is their terminology for, just give me the pieces I need to know. Year after year after year of being trained to talk in this way, when you're presenting to your attending physician, your colleague residents, it only makes sense that now we are having difficulty when we come into the actual room with the patient. And now we're supposed to not speak in a high yield way. So we're taught a completely different way to communicate with our superiors. And then we're supposed to go into an exam room or an operating room or wherever. And now be completely humanistic and come back to feelings. And that's just not reasonable. It's not going to happen. It doesn't happen. That's the whole point. Patients will come into the room, hopeful and, excited to share XYZ about their lives and how that ties into, the diagnosis or treatment. And it's just getting tuned out. That information is not high yield. And they've been taught to tune out information that's not high yield. And so, this gets to the point of obviously there isn't malintention, but this is the reality of how it's been trained out of them. There's this disconnect, right? So I can't even tell you how many clients I've helped who are like, that's what I've been trying to tell the doctor for 6 months, and how you just popped in and got it explained in 15 minutes. But it's because they're not it's they're on completely different frequencies. There's this gray space where it's the doctor's saying this, the patient's saying this, and the frequencies aren't matching up, but I know how to take what the patient is trying to say and speak it in a way that the medical team can process, can absorb and process and do something about. And that's a real phenomenon that's at play in almost every medical situation. And there's no necessarily, perfect fix for that, except for everybody to acknowledge it. This is at play, just like the illness identity, right? This is at play, whether we like it or not. This is how they've been trained. This is how everyday patients communicate, and it's not coming together. And so there is going to be a gray space, and knowing that, how do we navigate that gray space? So
yeah, and I think that's why the partnership, it has to be a partnership between the patient and the clinician. And just like with any partnership, you have to try to understand each other's sides and be empathetic to that and want to work towards narrowing that gray space. It makes me think of when I started my dissertation. Well, actually, it was when I first started my doctoral program. I've always considered myself a creative writer. And so my very first paper in my very first class, oh my gosh, was torn to shreds. I used analogies and, these kinds of things. And this was like, yeah, that's not scholarly writing. You need to go back to the drawing board. You need to cut the fluff. You need to get very direct about what you're saying. And that was really hard for me to shift gears. And so that, kind of illustrates how each side of the relationship, they come with this different way of communicating with each other. And there needs to be learning on both sides, I guess.
No, I think we can definitely find instances of that in our lives. I think, both sides having a better understanding of it is key, because I don't think all of the onus should be on the physicians to shift all of this, because their lives are difficult in a lot of ways too. So how can we better educate both sides, which is, part of the intention of the book, but the book isn't all the answer either. This has to be an active everyday process of really trying to shorten that gap in the gray space.
Yeah, and something else you mention in your book, you say sickness is a messenger, a yellow traffic light. And, I kind of spoke to that before, but that really struck me. I have felt dismissed at times when I've been in my physician's office and I'm like, hey, this is what's going on with me. And it never really gets addressed. Well, it doesn't look red. It looks fine. If it keeps happening, let me know and maybe we'll do something about it. How can health centers reframe their messaging in a way that empowers patients but doesn't shame them? Like, oh, well, now you're type 2 diabetes because you're overweight, because you're not eating the right things. Even if they don't say that, I think in the silent space, maybe patients are hearing that it's their fault.
100% they're hearing it's their fault and they're tuning out. And that's the thing, is like everybody's kind of tuning out. Like keywords are making everybody tune out at different points. Like, physicians are tuning out when there's too much fluff in the conversation. Patients are tuning out when they feel attacked, when they feel dismissed, when they feel that they're being blamed, that they did something wrong. I think, there's a lot of elements to this. And so I'm trying to say it in a concise way. I think a deep understanding and communication of the way that the body works and how it knows how to heal. So in communicating a diagnosis like diabetes, because what people understand of diabetes is just like, it's terrible. I'm going to like lose my legs. And, they just, again, is the illness identity. I think, the onus at that point is on the medical team to explain, if it's not type 1 diabetes and it's not a genetic, situation, but if it is something like type 2 diabetes, sharing real stories of how people have reversed this. This is what the state that your body is in right now is a poor metabolic state. And so whatever led to this up to this point doesn't matter nearly as much as what we do from here on out. So I think there's a way to communicate that in an empowering way. There's so much you can do in between appointments. So I think people feel very much locked into, I have this appointment, I really don't have any hope again until the next appointment. Like I'm just waiting for you to tell me that hopefully things are better, and I'm just bracing for the news that it may not be better. When really all of the work happens in between appointments. All you have right now is some objective data that suggests you have some metabolic stuff going on. You have metabolic syndrome maybe, and your body is not functioning optimally, but it knows how to do that. Otherwise, you wouldn't be breathing right now. You're not doing anything to make your heart beat and your lungs exchange gases, and your body is like insanely magical. So, and it's, very divine. And I think people, that isn't communicated to us. And so we just think this is the end of the world. But I think if the team would communicate, number one, success stories, or maybe that success stories play that are, people who are okay with it playing, play in the waiting room or play in the individual exam rooms while you're waiting for the doctors. Like they need to hear that this isn't the end. There are other people like me who have had diagnoses like this and have overcome them. And here's what they did. And, here's how long it took. And like, oh, this is actually possible. It's a continuous story that needs to play. And we have to, as the healthcare system, have to be a part of introducing people to those stories and encouraging them to lean on success stories and not lean on, what the TV is telling you about diabetes and what you think because of whatever, of Instagram, of, wherever people's attentions are. So empowerment is based in hope and vision, but in actual, also real stories. That's what people resonate with. And so we need to be able to communicate that to them.
Absolutely. I love that idea so much of success stories, because so many times we hear the unsuccessful stories. Like we're trying to scare our patients into doing the right thing instead of empowering them, uplifting them, filling them with hope that, hey, there is evidence of success in people that are applying this in their lives. And I just hope that this empowers healthcare professionals to step into that space where advocacy is really needed for the patient. And, we can kind of start bridging that gap. If you could give one message to health center teams about that are trying to do better, that are wanting to get better at empowering their patients, despite all the constraints that they have, what would you say?
If I had to say one thing, I would say bring the patient to the table, and not as an inferior part of the team, but as an equal. And that's really hard to do because we are taught we have superior knowledge, right? That's what we went to school for. And so there's a level of feeling of superiority. And I think if we can have humility and realize that the data that we can get from a patient about their own journey is some of the most valuable data we can get. And if we just bring them to the table, we can find out more in an hour than we can in a year of unproductive follow-up appointments. So I would say bring the patient to the table and be really humble and allow them to share what they know about their bodies and allow that to provide you some direction. Maybe that means you check different boxes, you check different labs than you would have otherwise checked. One example I'll tell you is I'm working with a client right now whose teenage daughter is dealing with some symptoms. I looked at her labs and I was like, well, where do you work? And she works in a Vietnamese restaurant. And I love Vietnamese food, but I also know that there's a potential that there's, are you dealing with raw meat there? What are you working with? And so, yeah, is there a potential she has a parasite? Probably, maybe, based on the symptoms and the labs that I'm seeing, but that's never been brought up because nobody's asking her where she's working. So bring them to the table, know more about them. And I think you'll be shocked at what you learn.
Yeah, one of the nurses that I worked with in the past, she actually started out in the ER and then, migrated to cath lab and then eventually OR nurse. But, she was talking about that one day saying, when you're in the ER and a patient that's like a IV drug user comes in and you need to draw labs, like you listen to them, they know where is the best place to poke them, and a lot of the, nurses that were working in there would be like, no, like they wouldn't listen to the patient and then the patient would end up getting stuck multiple times, and that was her point, was to be humble enough to listen to the patient and not just think that as healthcare providers, we have all the answers. If we listen to them actively, they'll probably give us a lot of the answers that we need.
100%. And it'll be so much more of a positive experience for everyone because they feel like on cloud nine that somebody's finally listened and your ability to help them is so much higher because now you have the data that you can't get from labs. There's data that exists that you cannot access unless you do this the right way. So, yeah.
Where can listeners find your book, and how can they connect with you if they want to?
My book is on Amazon. Super easy to find. You can just search my name, or you can search Patient Empower Thyself. You can kind of see it there. My website, where you can find everything too, is Consult Avanti. So ConsultAvanti.com. And then, you can also find me on social media. I'm most active on LinkedIn. So you can just find me by name on LinkedIn. And the link to the book is also there.
Awesome. We'll make sure we put some of those things in the show notes so people can just easily click on there if they want to get in touch with you or buy your book. I think it's a fantastic read. I've enjoyed this conversation so much. I think there's so many good points that came out of it. And just want to say thank you for your time. Thank you so much.
Thank you so much for having me. I really enjoyed our conversation.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.